Welcome to The Gut Show. I'm your host, Erin Judge, registered dietitian and founder of Gutivate. I'm also your fellow IBS warrior. Our goal on this side of the internet is to empower those with IBS and digestive disorders to understand their gut better, to have a healthier relationship with their bodies, and to make confident choices to improve their digestive health. During this season, you can expect a conversation around a hot topic related to gut health, digestion, and IBS. As a disclaimer, I am a dietitian, but I am not your dietitian. So everything covered in this episode is meant to be educational and is purely information that you can take back to your healthcare team in order to make the best decisions for you. If you're new here and something just doesn't feel right in your gut, if your symptoms have led you to this podcast, I invite you to start by taking the quiz, What's Your Poop Personality? Your personality type will unveil what your symptoms may mean, what may be causing them, and what you can do about them. This is a free quiz and you can take it today at gutivate.com or find the direct link below in the show notes. While you're going to take the quiz, let's jump into today's episode. Welcome back to The Gut Show. I'm Erin Judge, and I'm so excited because today we have a special guest, Natalie Menedius, who is one of our Gutivate team dietitians. Natalie has had around 5 years of experience at UCLA Division of Digestive Diseases and has a lot of experience with complex GI patients. She's also been involved in training dietitians and GI fellows, lecturing different physicians and community members, and serving as a member of the inflammatory bowel disease work group of the Academy of Nutrition, Dietitians in Gluten and Gastrointestinal Disorders. It's a big mouthful. All that to say, Natalie has been working with GI patients for many, many years. She has also been involved in how dietitians as a whole get tools for working with patients, because GI nutrition is not something we all learn whenever we become dietitians. So through her learning and practice, she's been able to share those tools. And then she's been with Gutivate for 2 years now, which is wild. And so she's been working with our patients with glowing reviews. So I'm so excited to have Natalie here. And Natalie, welcome.
Thank you.
Yeah, I would love for you to start with a little bit more background. I didn't get totally into like why you became a GI dietitian. So I'd love to hear a little bit more about your background, becoming a dietitian, and why you decided to focus on GI and especially conditions like IBS.
Yeah, for sure. So like many dietitians and many healthcare providers, I feel too, I had my own experience in the GI realm and navigating the healthcare system. And that all started when I was 13. I remember going to a place in my hometown where we'd go for like soccer parties and birthday parties. And I had a calzone, and then I was up all night, super sick, like some really bad foodborne illness. And from there, I remember being a kid and like not feeling well, but I couldn't articulate what it was. I remember I had difficulty swallowing, and I would just be sitting on the school bus, like watching kids swallow and wondering like how you do that. Like it was a very strange experience. And I lost a lot of weight. I couldn't tolerate a lot of foods, but that was kind of like my first experience with it. And I started seeing a GI at that point. But I don't really remember what happened between then and college. And then at 23, I did the classic like post-college Euro trip with my friends. And it was another round of foodborne illness where I blame the Czech goulash. But my friend and I were both super sick, and we were traveling at the time. So I remember like deliriously stumbling through the streets of Prague, just trying to find like the Czech equivalent of Pedialyte. So that wasn't great, but both she and I, like, we had the same bug, and then she came back and she got better, and I didn't. And I remember going through that process where I was like just fresh out of college. I was excited to start my career. I couldn't work full time because I was feeling so sick. And I remember like going to the GI doctor, having those conversations. I remember like trying to work and get some work experience, and then calling my mom being like, can you please pick me up because I cannot ride the metro home, I'm in too much pain. So that was like a lot of my experience at that age. Basically, I saw the GI doctor and he gave me a list of like 6 different medications, and he was like, take this for this symptom, this for this symptom, this for this symptom, and he kind of sent me on my way, and this is your life now. So I was 23. I was like, I'm really not satisfied with that answer, and I really don't want to rely on so many medications to feel normal. So that's what led me to pursue nutrition and public health. But it really wasn't until going through grad school where I like realized I loved the GI nutrition piece. So I had thought I was going to work in sustainability and food systems and spent a lot of time doing that because I really wanted to figure out like how can we prevent these types of things from happening and just make our food system more supportive for health overall. But when I went through the clinical training to become a dietitian, I rotated at University of Michigan, and they have a really great GI program, trained with Emily Holler and some of the great physicians there. And it was just in seeing that process of how impactful nutrition and lifestyle really were for the GI patient that I fell in love and had to change course at the end of my training. So that's what got me here. And that's what really motivates me is like I remember how bad it was for me, and seeing people who can get better with food and lifestyle is really empowering.
It's amazing. I feel like it's so interesting how many of us in GI have similar experiences. And I think that that's something that's really beautiful because navigating the system as a patient gives you a lot more empathy, but also a lot of understanding of where there are gaps and what things to say, how those experiences actually go, and how to prepare for them. And so, being on the side of it as a provider, especially a dietitian, where we're working with patients for a large amount of time, usually, right? Long-term care, but also, many hours in sessions versus quick little appointments, we're able to empower patients with those tools. But if we don't know what it's like to navigate it, sometimes it can be hard to even know how to empower them with the tools, which is really what the conversation that we're having today is all around. So if you're tuning in, we are going to talk all about navigating the healthcare system, specifically with labs and testing. And this is a hot topic because with IBS, a common complaint that patients have is that there's a lack of testing done before their diagnosis. And that can often lead them to feel like either their diagnosis is fake because nothing was tested for. So, how do we know? Or they're not confident that the diagnosis is, I mean, kind of in the same vein, like real, which means, okay, is there something more that's wrong, which leads to a distrust of themselves and their medical provider, their body, all of that, which is not what we want as providers, is to leave our patients feeling more confused. So when it comes to a lack of testing, specifically for an IBS diagnosis, can you explain a little bit of why this happens, where the lack of testing comes in, and why, some tests may be done versus not?
Yeah, so I think there's a common misconception that IBS is kind of like a throwaway diagnosis, or like we don't know what's wrong with you, so you probably have IBS. I think part of that stems from a lot of it's how the provider speaks to the patient about the diagnosis, where if so many of my patients are like the provider will say it's just IBS, and that really trivializes their experience. So I think that can be part of it. The other part of it is there are specific diagnostic criteria for IBS that were developed by the Rome Foundation, which is a group of specialists in what are called like disorders of the gut-brain interaction, and IBS is under that category. And it's specific symptom profiles they're looking for in order to diagnose IBS. And part of that's to avoid like excessive testing, because there can be some trade-offs with that, where sometimes people want to do like a whole battery of tests, and it may be overuse of testing, but it also in some cases can lead people down rabbit holes too, of like expecting or really wanting something to be positive and then it's negative, and that can be like emotionally draining for the patient too. So yeah, but generally I would say there are criteria that should be met in terms of if someone has IBS-D versus IBS-C, what types of testing should be pursued. But then if you've done some of the basic testing, then typically that can be sufficient to diagnose IBS at that point.
Wonderful. And I actually don't know the answer to this, so I'm curious if you do. I don't know if we do, because we're not diagnosing. I think we should clear that up. As dietitians,
Yeah.
we don't diagnose, and we can like kind of encourage testing. We can order some tests, like some blood labs, but we can't really order a lot of tests or even interpret a lot of tests for a diagnosis. We don't diagnose, so that's not what we do. So I just want to clear that up too. We're here to help provide education around this, but obviously we're not doing that. That is the role of the doctor, or physician assistant, or whatever that would look like in your state. But I'm curious if you know, because I see a lot of patients with IBS who are, coming to us or on social media or whatever, and they're like, well, I was just given this diagnosis offhandedly 10 years ago, or 5 years ago, or 20 years ago, and I never trusted it because my doctor did no testing. Do you know when the Rome criteria actually included which tests should be done for different types? Like, is that within the last 10 years or even 5 years?
I think they updated the criteria, I want to say in 2016. I could be wrong, but I do know that the ACG, the American College of Gastroenterology, they came out with a paper. I'm not remembering what year it is. It's sometime in the last 5 years, but that was saying like what the algorithm should look like if someone specifically has IBS with diarrhea to rule out other potential conditions like celiac disease or inflammatory bowel disease. So I know that exists, but I don't know like at what point in time the diagnostic criteria may have shifted.
Yeah, I don't know either, but I don't think it's that long ago when we look at like healthcare as
Yeah.
a whole. So, thinking about the criteria that Natalie's talking about, if you were diagnosed 20 plus years ago, there is a chance that that criteria wasn't followed or that algorithm wasn't followed because it may not have actually been in place, which is important to remember. As we get into some of the tests, you already mentioned, celiac disease and inflammatory bowel disease. But what are some common warning signs to ask for more testing, or that maybe a doctor would highlight as like, oh, this is a red flag, we should probably do some more testing? And how can patients best ask for these? Just kind of start the conversation around more testing with their doctor.
So, common red flags or warning signs we'll be looking for. One would be weight loss, which can be tricky because weight loss can happen for a lot of reasons in GI conditions, but that would be one potential red flag. Another is blood in the stool, which can also be tricky because that could be related to hemorrhoids, but we don't want to just assume that. It's important to talk to your provider about that. Another is if someone's over the age of 50 and they have a sudden change in their bowel habits, that's where physicians are starting to consider like the risk of new onset GI cancer. That's also challenging because that's changing, where there's an increasing rate of young adults getting diagnosed with GI cancers, especially colorectal cancer. So I'm curious if that will change, but as of now, over age 50, that's one way to think about it. Another might be if there's a family history of cancer or inflammatory bowel disease. So if someone's showing up in a clinic and they're suddenly having diarrhea out of the blue and multiple family members have Crohn's or ulcerative colitis, then that might increase your diagnostic suspicion for IBD for a clinician. Another is unexplained anemia. So if there's anemia and we don't necessarily know why, usually a GI physician should be checking like labs for that, like a blood count. They can check your ferritin. That's sort of assuming they have the data already, but otherwise we want to make sure that there's no cause of GI bleeds, and they can do that with further imaging. And then another would be vomiting or like difficulty swallowing.
And what about starting that conversation? So you have a red flag. Ideally, we're communicating those red flags. But let's say these red flags are showing up, or maybe have been present but haven't been further evaluated, or something has just drastically changed, right? Maybe it's not fully one of these red flags, but you're suspicious that things are changing. You feel it in your body that things might be progressing or changing or not going like your doctor maybe communicated or like you hoped it would. How would you recommend people start this conversation? And especially with your experience, in a bigger healthcare system where you're working alongside many different physicians, what kind of language helps, or, just the conversation itself? How can patients be empowered in that to maybe pursue further testing?
It's interesting because I find certain demographics are more inclined to like downplay their symptoms. We call them like minimizers. So some people are like, oh, well, I just have this. And a lot of that can influence how your provider interprets that data. So I think part of it is conveying the importance and how abnormal this is for you. So if you're like, there's blood in my stool, even if you say have hemorrhoids or there's a known history of that, not downplaying it to your provider, but being like, look, I've noticed more blood in my stool. I'm concerned about it. What options do I have, or what do you think we could consider here for evaluating it further? Or what are your thoughts on why that may be happening? Let's say you're having a symptom like blood in the stool, and then you talk to your provider about it, and they're like, it's probably just related to your hemorrhoids. Then if that's not the answer you want, or if you are concerned about something being more of an issue there, then I think also punting it back to them and being like, okay, if it is hemorrhoids, how can we monitor this? And at what point should we be considering other alternatives? So in that way, it's not on you as the patient to be like fully advocating all the time. Like your provider should also be aware of like what's shifting in your body and what to evaluate. I think a lot of it is the other piece of trusting your provider, which I'll probably talk about later. But if you don't trust your provider, that can be a huge issue in terms of like if they tell you no more testing is needed, but you don't believe it, then that can impair progress.
Absolutely. I think that's that partnership piece, right? And that's when everyone always asks, well, how do I find a good provider? How do I know if my provider is good? And ultimately, we don't always know, and that's tricky. And people have bad days, they have good days, like things get lost in systems, things are communicated, things can happen. And that's the downside to just healthcare as a whole. But if you don't have that partnership with your provider, then things are more likely to get missed. That conversation is more likely to get cut off, or you are less likely to maybe get what you want out of it. So you showing up as a partner, but also looking for someone who's also showing up as a partner, and
Yeah.
feeling that out. And if it doesn't feel right, if you have the option to go to someone else, go to someone else. Like, don't feel like you have to go to the same person. That's really helpful and important.
Yeah.
Okay, so now getting into some of the specifics. What are some of the common tests, including different blood tests, that you would possibly recommend for patients with IBS, or that could possibly be done? And we'll give this the caveat of, obviously, this is not us saying, if you're listening, you should go get all of these tests done. We are dietitians, and these are things we may do for, like, recommend for our patients more one-to-one. So I know we'll get into like different signs that tests may be needed. But this is to help hopefully just give you some insight into the tests that are out there if your doctor has brought them up, or you've heard them tossed around and you're just not really sure how to navigate it. So
I will say, so one thing would be the celiac blood test or celiac antibodies. I would say that's even more true if you have IBS with diarrhea, if there's some unintentional weight loss, if there's family history of autoimmune disease, or if you're someone who's like, I went on a gluten-free diet, my symptoms like 100% went away. That could be another potential increasing the suspicion of that. So that would be one. The one thing I'll say with that is that's only valid if you're consuming gluten. So if you've been on a gluten-free diet for years, then we would want to consider other markers to evaluate that. So that's one. Calprotectin is another one, and that's a stool test that can be done. That can be used to detect inflammation in the GI tract. So that's different than a CRP or C-reactive protein, which is a blood test. So sometimes if a provider is suspicious for something like inflammatory bowel disease, they might check CRP plus calprotectin. And in that way, they can see like more full body inflammation on the CRP, and then calprotectin is more localized to the GI tract. So that's one where if you're noticing like blood or mucus in the stool, significant bowel movements, family history of IBD, we might be thinking of that. Beyond that, I would say stool testing can be done for other things. For example, like H. pylori is one they can do a stool test for. Some debate on whether that's the most precise marker, but there's that. If someone just had a foodborne illness, they can screen for things like parasites and ova and that sort of thing. But in my experience, I rarely see those positive, because the farther you get out from the initial exposure, the less likely it is to be like that. So I would say those are more common ones. And then there can be more specific testing for like colonoscopy, endoscopy, imaging, all that. But in my experience, that's not usually a provider starting point unless they're concerned about something like IBD or cancer family history.
and then what about those more on the constipation side? Are there other tests that might be done if, let's say, the constipation has become more prevalent and the IBS side of like IBS-C isn't improving? Like, are there any options there?
Yeah, there's a lot. So there's different subtypes of constipation. So there's one that can be like under the IBS umbrella, but you can have multiple types of constipation. So one example is someone could have pelvic floor dysfunction. That's part of their IBS with constipation. And those are typically the people who are like, I'm spending a long time on the toilet, or I have to shift around to get a bowel movement out, or and in those cases, they can do a test called an anorectal manometry that's looking at the mechanics of the pelvic floor. I don't see that as often in like small community settings, but more like academic health centers like UCLA. But that can be really helpful to understand like what's actually happening when you're trying to have a bowel movement. And it can be really validating for the patient to be like, okay, it's actually not normal to spend this much time on the toilet. So that's one for the IBS-C. And then there are, I will say I see this less often, but there are studies like a smart pill study that can look at your full gut transit time. And I love those tests because you can get a sense of someone's individual like motility. But I typically only see those done if someone isn't responding to things like laxatives that their GI provider is prescribing, and they're trying to understand, is this truly like a slow transit constipation? In that case, it kind of changes the way that you manage it. So those would be the two more common ones I see in IBS with constipation. And thirdly, a SIBO breath test is pretty common, I would say, especially for patients with constipation. They're more likely to have elevated methane levels. So, and that can be a chicken or egg scenario because it slows down the motility, but then constipation can lead to methanogen overgrowth. Methanogen overgrowth can further slow the gut. So, yeah, I would say those are the tests I'm thinking of.
Yeah, awesome. I'm glad you brought up SIBO because I know a lot of people like SIBO testing is widely available now, right? It's something that you
Yeah.
can order yourself if you want to, which is amazing. Being able to order tests is helpful as long as you have a provider that's willing to monitor that with you and treat you, which is the hard part. But SIBO has definitely risen in the IBS world, and there's a lot of marketing around it. Obviously, some of it is a little ahead of the science, but the tests themselves can be really helpful. How often do you see SIBO tests done, especially in the clinical setting? How often would you recommend it? Or you mentioned, testing for methane. When would you recommend other SIBO testing, for different patients?
So SIBO is, I feel like we're learning so much now about SIBO and also just like the whole microbiome in the small intestine. So there's still a lot we're learning about it, but I would say SIBO breath testing, it's not a perfect science in the sense of you could take some healthy people walking on the street and they can test positive for SIBO. So I find a skilled clinician will correlate symptoms with the actual test result. And I've had cases where they test negative for SIBO and the provider treats them anyways and they feel better. But SIBO breath testing, I find providers tend to vary in their opinions on it, where some of them are like not willing to do them at all. Some of them will just treat it based on the symptoms. Others are repeating the tests more often to see how it's changing over time. But typically with SIBO, I'm more often thinking of SIBO if someone has like really relentless bloating, and then there can be different subtypes of SIBO. So if it's hydrogen predominant, you might find someone's more inclined to diarrhea. Methane predominant can be more constipation. And that's what I see most often with SIBO.
What about the kind of IBS diagnostic test? So as of maybe, the last many, many, many years, I guess until maybe 10, I guess around 10 years ago, 8 years ago, whenever it came out, we had this belief, and I think some people still hold it, right, that you can't test for IBS. There's not a diagnostic marker. Well, there's some research in the SIBO world too that has shown that there might be some markers of post-infectious IBS. And so I think there's one test on the market, maybe there are more, but there is this now ability to test for one marker of IBS. I'd love for you to cover that. What is that marker? And when is that tested, or how is that tested?
Yeah, so it's commonly known as like the IBS Smart test. It's a blood test that's looking at antibody levels for two different markers. One is called antivinculin antibody, and another is anti-CD/TB antibody. And those, there's some research showing that those can be elevated for someone who has post-infectious IBS. I'm curious, one question I have that I actually haven't looked into is like, how does the timeline relate to it in terms of like if I would presume if you're farther out from the infectious episode, it's going to be lower, but I could be wrong. But in any case, those markers can be helpful for someone who has like a post-infectious IBS picture in terms of like giving you something diagnostic to work from and prevent you from having to go through the colonoscopy and like all the procedures and whatnot. But they are really more effective for people who have IBS-D or IBS mixed, but less so for patients who have IBS-C. There's also some thought that those tests could be helpful in terms of correlation with SIBO, and like the magnitude of the elevation of those antibodies could affect like the likelihood of the SIBO or the severity of the symptoms. So that can be helpful for people just who have been like going through it with a post-viral event to have something to point to, like, okay, this is what's wrong, and now I can proceed with addressing it.
Yeah, awesome. I find that with doctors that I've worked with and patients, that the SIBO tests are kind of more often an option compared to the anti-vinculin, anti-CDTB, but I
Yeah.
don't know. It's hard to know like which one doctors are going to go with, especially when you get into some of these tests that aren't part of the algorithm that Natalie referred to at the beginning. Some doctors may be using them, some may not, and they may not feel the need to. If you're ever curious why they're not, you can always ask, like, why would we
Yeah.
not? What else are you considering? Sometimes they have maybe the algorithm in their head, or they have so much experience with a certain, symptom pattern that they can treat you or kind of navigate that treatment without the test. But you can always ask, which is always helpful. And then I know we didn't really talk about like annual blood work that you get through like your annual checkup with your doctor. We've talked a lot more about what you're getting from a GI doctor specifically for the treatment of IBS specifically, or chronic digestion symptoms, and trying to get a diagnosis for that. What about navigating annual blood work? How important is it to get this blood work? Like, what are we really looking for with annual blood work? And how can you approach that as a patient with getting your blood work? Like, how do you evaluate it, or what do you do with it?
Yeah. So are you thinking more for the IBS patient or just like as a general
For
patient?
both. Yeah, I think as a general person, right? A person who has a body that lives in wherever you live, and this is an option for you. But especially if you are dealing with some sort of health complaint or chronic symptoms, or something doesn't feel right, I think sometimes we bypass this to go towards GI, where we may not be getting these kind of annual labs, or the GI might run them, they may not. So we're not really monitoring them annually if you're trying to deal with a condition. So what do these fit in, and what's their purpose?
Are you listening to today's episode with the main thought being, what are the steps that I can take to get rid of my symptoms right now? While I hope that the information that we share in every episode of The Gut Show leaves you feeling more empowered and more confident in your body, it's not always going to solve your problem or give you a clear direction for your specific symptoms and your needs. The Master Method membership is an online program for the person with chronic digestive symptoms and IBS who wants step-by-step guidance to understand their body, address the drivers of IBS, reduce symptoms, and build resilience in your gut long term. This membership includes a step-by-step course and a dietitian-led community that teaches you how to holistically address each symptom and the IBS drivers, how to reduce symptoms more strategically and with confidence, and guidelines for better gut health long term so that you're not only thinking about today, but you're also improving your outcomes in the future. It is time to ditch the symptoms and get your life back. The membership is your first step. You can learn more and enroll at ibsmastermethod.com and use the code GUTSHOW, GUTSHOW, GUTSHOW for $25 off your enrollment fee. Now, let's get back to today's episode.
I come at this from the lens too of like my master's is also in public health, and I believe very strongly in the power of prevention. And I think there's some challenges in our healthcare system in terms of like how much monitoring do you do and how much prevention can we do in this type of setting. But if I had my choice, I would say like absolute bare minimum, a patient should be getting like a complete blood count that can give you a sense of things like hemoglobin and iron status and that sort of thing. Comprehensive metabolic panel, and that can give us a sense of like how well are your kidneys working or how well is your liver working. I would say that's especially true for anyone that's taking like long-term supplements, especially if it's herbal supplements. Like at the very minimum, you should be checking your liver labs as part of that. And that's because those can elevate with like prolonged supplement use. So those would be two I'd check. I think for general like metabolic health, I like to see a lipid panel. Depending on someone's like cardiovascular risk history or risk profile, they might add on other things to that, but generally lipid panel bare minimum. Hemoglobin A1C is one that I'll check or ask to check once a year at least. If someone has issues with blood sugar, it's going to be more often than that. Beyond that, for the GI patient, I think everyone, in my opinion, everyone's vitamin D should be checked at least once a year. There's so much research coming out about vitamin D beyond its role in bone health. It's like it's also part of the intestinal immune system and it's part of mental health. It's like implicated in so many things. So I feel like everyone's vitamin D should be checked and really at an optimal level, especially if you're like living in the northern hemisphere and don't get outside. So that would be another. And then for menstruating women, I think I like to check iron status, which I ideally I would check that with like an iron panel plus ferritin. Ferritin's your storage form of iron, and I find for many menstruating women, the ferritin can run lower. And then if you're feeling like super tired and depleted, if your ferritin's low, then I might be thinking of iron repletion for that person. Um, and then B12 is another one that your liver can only store B12 for up to 2 years. So especially if you're someone on a plant-based diet or not, that would be especially important to monitor. So yeah, I think those are the main ones.
Awesome. And if you're getting those labs, like as a patient, what do you do with it? And even like the tests that you get from your doctor, do we simply get our tests and like wait for the doctor to give us the results? Or like how can a patient be empowered even with their tests, but especially these kind of more monitoring prevention style tests?
Yeah, so the way I would think about labs is like on a high level, be considering someone's trend and what is quote unquote like clinically significant. So I could have something like, for example, one of my markers on a blood count, like a mean cell hemoglobin, that could be like lower or higher than usual. Maybe I was dehydrated when I got the test done, and that's why it's out of the range. So sometimes you'll have the lab might flag something as being abnormal, but it's not necessarily clinically significant because it's just a random outlier that doesn't have application to your scenario. Where I would focus more is like, how do the trends look over time? And then how does that overlay with your symptoms? So for example, like I had one patient not too long ago, his ferritin was, I think he was like in the 600s, and he was a long COVID patient. His providers were like, I think it's probably just the long COVID and that's probably why the ferritin was elevated. And I kept seeing him and I was like, he's really tired, his mood is low, like he's really not feeling well, and his ferritin just keeps going up. So I had him go back to his primary care provider and I was like, maybe ask them for a consult with a hematologist. He saw hematology, they're like, you have hemochromatosis, which is a condition where you have iron overload and it can affect the liver. So now he's getting like his iron therapies, he's feeling so much better, but it was something where like the labs were clearly trending up and he was feeling worse. And I was luckily seeing him a little more often, so I was able to kind of intervene on that. But that was a clear example of like the clinical pattern matched the labs and it was going in the wrong direction. So I think just having an understanding that like if one lab is abnormal, we don't always need to panic. We want to know like what's true for your body and then what is the overall trend that we're considering, whether if it's going up or down and all that. So
Awesome. And that does bring back the importance of actually getting the labs because you can't
yeah.
see trends or know how trends are going if you don't actually get the blood workup. And I think a lot of times patients, especially in GI, especially with IBS, like they're fatigued from seeing doctors. And I do see it so often where their primary care visits completely fall off until something's wrong and we're not getting these labs, or we're assuming that like our specialists might do the labs for us, but they may not be thinking about it unless they're reacting to a change in symptoms. They may not be monitoring your annual like prevention side, or kind of keeping up with some of the other pieces like metabolic health or whatever it may be. Even if you're on supplements or medications, sometimes they're not thinking to check for your liver and how it's doing in those short appointments. So as a patient, being empowered with that, like actually going through that, if it's especially if it's covered by your insurance and available to you, getting it scheduled, going through with it, monitoring over time, keeping up with that information, it can be really helpful. So I'm glad that you brought that up.
Yeah,
uh,
yeah. And I'll add too, like I think there's a tendency to like blame the providers or especially blame doctors. And I think understanding the other side of healthcare, like we work in a system where there is like very high demand for healthcare and there's like a constant request to see someone. And it's just like a never ending revolving door of like wanting to take care of your patients, but not having enough time or resources. So I also approach my providers with that knowledge of like, okay, I know my body best. They are the specialist on this area. And so knowing that I'm experiencing these symptoms, what could we evaluate for? And kind of like being the advocate coming from the standpoint of like this partnership we talked about. And I'm the
Yeah.
specialist on my body, but you're the specialist in this area. So how do we work together on this?
Yeah. Yeah, I completely agree. You have to take that responsibility of your own care and like your own progress, because again, the system could, like the healthcare online portal could mess up and something could get missed. Like we as patients do have to always kind of take the driver's seat. And if you have the means and you can, pay for someone that is taking that with you, like an advocate on your team. I always say that with, your healthcare team, finding your advocate who spends the most time with you, who has more time to listen and kind of pull that data together, who can help you put together plans for doctor's appointments. You may have that included based on your health condition. Like that might be something that you have available to you. That's something you could ask your doctor for. I think there are patient advocates also. What are they called? My brain is blanking. Is someone who helps coordinate care.
Social work
It's like social work and
or
that
care
side of it.
coordinator.
Yeah, care coordinators, that these exist. So always ask, especially if you've been diagnosed with a condition that might be available to you, always ask your doctors. But there are also other providers that do. That's something we do a lot in our practice because our patients pay for extra time outside of sessions to have that done in a way. And we try to do that as much as we can. So that's something too to look for if you're like, I'm exhausted navigating it all on my own. But at the end of the day, you do still have to keep up with the information and, communicate it and all of that, which we'll validate is a really hard job, but it can make such a big difference in how you spend that time. So now getting onto kind of the opposite side of this, right? We've talked a lot about testing and it sounds great because it's like, great, ask for these tests. If they're needed, they'll be done. They're going to tell you great things and then you'll get treated. But there is a side of it that's maybe a little bit darker, that sometimes tests can be done thoroughly and they can come back completely normal, completely fine, no negative trends, no outliers, nothing is seen, but symptoms are still present or in some cases even worsening. So what would you say to the person that's listening and maybe experiencing this right now?
Yeah, that can be tough. And I think a big part of that is, like I mentioned before, like having that trust with your provider so that you're not going on kind of like an internet rabbit hole and coming back that I need to do 20 different tests sort of thing. But I would say one of it is maybe if you're skeptical of it, like asking your provider, like, is there a reason you're not suggesting more testing in my case? And would if this changed, would that change your approach to it or something like that? So kind of understanding like the rationale of the provider. One way I'd think about this is at what point is it like you're instilling this trust in your provider and you trust that they've done the appropriate workup for your case, and now like we can assume that if they gave you the diagnosis of IBS, that's what you're working with, and how do we go forward knowing that information? That's one piece of it. The other is if it is a question where you really don't feel like you have that trust, then maybe it's starting to build out your team in other ways. So maybe if you have a physician and maybe you're not as certain on that, but say they've said you have IBS, then how can we start addressing this from like a whole person approach?
Along those lines, also, right, asking for referrals, like you talked about earlier with your example. I think oftentimes, if your symptoms are getting worse, you can always ask, how are we treating the symptoms or what are we doing about it? But also, you've done your workup. Is there another referral that you would have for me as a patient? Like, because these symptoms are problematic, or is there anything else in my body that could be contributing to this that could be looked at by someone else? Those are always great questions to ask that I think sometimes as patients we forget, or we think like, oh, well, I'm going to GI. They're going to know if I need to be referred to like rheumatology or if I need to be referred to, neurology. Like there's so many places you could, endocrinology, there's so many places you could be referred. And sometimes they don't see it. Or again, back to the patient taking accountability for their part of it is we don't communicate it as patients. We may not communicate like, hey, I'm also dealing with this level of fatigue and this is how severe it really is. Or I've noticed that my migraines are getting worse in addition to my diarrhea. So, is that related? Like communicating that, but also asking, hey, you've done your workup and I know that that has come back negative. how can we treat this together and address the symptoms, but also, could there be another referral or another specialist that I should pursue, an evaluation with, that may be able to kind of dig into this as well. And sometimes that will help. Sometimes you'll just get passed around, and I think that's the reality of the healthcare system too. But you can always ask and keep fighting for some answers while also moving forward with treatment plans, and again, being more of a team and deciding not just like, I don't trust you because all my tests are negative, but what else can we be doing, and then also what's our plan moving forward.
Yeah, for sure. I think part of it too is you have agency, and like you should share the decision making. So if your doctor says, I think you should take this medication, if you don't want to take that medication, you should have a conversation about it rather than just like never showing up in their office again. There can be these trade-offs between like seeing a ton of different providers and then just like having too many cooks in the kitchen in one sense. But then in another sense, if you have like an interdisciplinary team where maybe you see a dietitian or maybe you see like a pelvic floor PT, then you're getting multiple set of eyes and different specialties on a similar issue. And that's where I find like the most effective care comes from, is like I as a dietitian might be thinking of certain areas, and maybe there are red flags to me that the doctor couldn't have found in their 15-minute appointment with them because they don't see them very often. So in those senses too, like if there's a direction you're leaning towards where maybe I know I need to work on the stress piece, or maybe I know I want to work on diet and lifestyle, having those teams come together can be really beneficial. I had that recently where like one of my clients that I saw with you, she really was not feeling well for a lot of the time we worked together, and she had debilitating pain and she couldn't go to work, and like her providers, like they kept telling her it was stress, and I was like, I know she's stressed, but this level of pain does not explain what's going on. And I was like, I kind of feel like she might have something going on, like with endometriosis or something gynecological. She emailed me a few weeks ago and she's like, Natalie, I finally saw someone who took me seriously. I have endometriosis and I'm on the appropriate treatment plan, and I finally feel like a normal human again. But if it weren't for you, like I wouldn't have known to ask those questions. So it can be like a daunting process to do it yourself. So having the right people, I think, is so huge in that.
Absolutely. I completely agree. And again, find those people. If you can't, you could work with us. True, over here, we're available. But there are options out there beyond that too. And if you feel like I've reached the end of my Googling for like, the answers, Google for the person that's going to help you advocate for yourself. And sometimes that advocacy is asking for further testing, seeing a different specialist. Sometimes that advocacy is getting validated in the symptoms you are experiencing, noting that they are actually real symptoms, and having a plan for those symptoms, because sometimes we can figure out what's causing them. Sometimes we can't. Also, sometimes trying to address them helps you then get to the answer of what's causing them. Like you mentioned, right? I see this, endometriosis is the most probably referred thing that I see in my practice as well. And it's usually after we go through IBS strategies, we're tracking the menstrual cycle, we're looking at symptom patterns over time. Like we're trying to address the pain with everything that we know can address pain. And if it's not working, then we can say, actually, this patient has done all the right things. Like this patient is managing stress. They are working on this. They have changed their diet. They are moving their body. They are like, they're doing all these things. And what comes out of that becomes more clear, which then leads to a referral, the right test, whatever it may be. So that's another side of it, of you might get testing on the front end. You might get someone who does an assessment and like, does a full workup. You may not, but that doesn't mean that you're at the end of the road. And that's, again, that teamwork of you and your provider, but also the providers that you've built as your team working together too, which is so important.
Yeah, for sure.
Yeah.
Yeah, I think there was a study on that in therapy specifically that talks about how like the handed most important thing with a therapist is like the therapeutic bond and not necessarily the method they're using. And I feel like that's true with a lot of other types of medical providers.
Yeah, absolutely. I've seen some patients where just simply having support from someone makes all their symptoms go away. Doesn't
Yeah.
happen all the time. It's probably, I would say, very rare. Maybe once a year this happens, where it's the golden, just communicating what's happening, having a little accountability to like some habits in your life. Sometimes it fixes the problem, which is wild, but I think it also shows how isolating or how isolation and trying to be by yourself and kind of like putting yourself in a bubble, like with distrust all around you and kind of disconnected from everyone around you, like how much that can be detrimental, especially in cases of IBS where it is impacted by gut brain, it is impacted by habits over time. Like there's so much nuance to it that's not as straightforward as, you know, you have this thing causing this disease that needs to be removed, or, you know, whatever that we see with some other conditions. So all very important. And I'm so glad that we got to talk about this, Natalie. Natalie is a dietitian on our team. So if you do want to work with her specifically, you can. I will put some information in the show notes. But Natalie, thanks for joining us. Anything else you want to share before we close down the episode?
I think I'll just say for anyone listening to this, just know that you're not alone. I think in general with like any chronic disease, isolation can be a big part of it, and feeling like if there's no hope with what you're going through or no one understands what you're going through, then find your people. And if it is someone who has the same condition, or if it's a partner who knows how to support you when your symptoms are flaring, that can be a game changer for how well you feel, because of that whole mind body piece and the social connectedness and all these things that really do influence our health. Even if there's not a single randomized control trial looking at that individual variable, like we know these things impact health. So yeah, I think find your people and hang on hard to them.
It's a perfect way to end this. So if you enjoyed this episode, give us a shout out on social media, share what you learned. You can also message me if you don't want to put it in your stories, totally fine. Again, all of that's in the show notes. And we'll see you next week.